Hi, everyone. I'm Seung-Hyuk Kim, Professor Emeritus of the Seoul National University Hospital and immediate past president of the WFUMB. Now I'm running a kidney specialty imaging clinic, K-Radiology Clinic. It is a pleasure to participate in WFUMB 2022 Romania. I was asked to talk about ultrasound of the urinary tract, the role for the clinical decision. This is an example of a report of kidney ultrasound covering the kidneys, ureter, and urinary bladder using in my clinic, and it contains most of the important items checked while I am doing ultrasound. And I would like to talk in this sequence, including kidney size, cortical echogenicity and cortical medullary differentiation, Doppler resistive index, focal lesions like masses, stone, or hydronephrosis, and urinary bladder. Kidney ultrasound is done with the patients in both right and left lateral decubitus and supine postures, and prone posture is usually unnecessary. Kidney size is estimated easily by measuring the renal length, but I strongly recommend measuring kidney volume from the length, width, and thickness and multiplying those three diameters and 0.5 to 3. This volume information is much more useful than the length information only in following the patients with medical renal diseases. In general, normal length is between 9 to 12 centimeter, while normal volume is between 100 and 200 milliliter. Next thing we evaluate is renal cortical echogenicity and cortical medullary differentiation. The normal echogenicity of the renal cortex is usually slightly lower than the echogenicity of the normal liver and spleen. Renal medullary echo is normally lower than renal cortical echo, and this difference is called cortical medullary differentiation. When the kidney is involved with certain renal parenchymal diseases, such as glomerulonephritis, renal cortical echogenicity is elevated, and cortical medullary differentiation may or may not be obliterated. In this patient with IgA nephropathy, cortical echo is slightly higher than liver echo and splenic echo, but cortical medullary differentiation is preserved. In this patient with glomerulonephritis, cortical echo looks normal, but cortical medullary differentiation is obliterated. It is easy and clear when we consider cortical echo lower than liver or spleen echo normal, and the renal echo higher than liver or spleen echo abnormal. But it is a problem when cortical echo is the same as the liver or spleen echo. This is an old but important article reporting that renal function was normal in more than 70% of those patients with renal cortical echo, same as the liver or spleen echo, and we should consider it is normal if cortical echo is lower than or same as the liver or spleen echo, and consider abnormal only when the cortical echo is higher than liver or spleen echo. Next is Doppler ultrasound. And I know that Doppler ultrasound, especially spectral Doppler ultrasound, is not included in many renal ultrasound examinations, but I think it is not a proper exam if we omit spectral Doppler, because this Doppler spectral information is important and sometimes very critical in clinical decision making based on ultrasound findings. Among the various Doppler spectral indexes, the resistive index is most commonly used. The resistive index is calculated by systolic minus diastolic divided by systolic height. It is usually lower than 0.65 and seldom exceeds 0.7, and this 0.7 is commonly considered an upper normal limit. In other words, the height of the endodiastric should be at least 30% of the height of the peak systole. The normal registry index is different according to the patient's age. Registry index in young children and old people is slightly higher than registry index in young adults. When you take Doppler spectra to measure the registry index, sampling location is important because the spectra are slightly different according to the sampling vessels. Registry index in the bigger segmental artery is slightly higher than that of the peripheral smaller arteries. So among the renal artery branches, including segmental, interlobar, arcuate, and interlobular arteries, the best location is an interlobar artery, which is quite peripheral and has an optimal Doppler angle. As you see in these two patients, the registry index measured from the Doppler spectra is very important. The left side is a normal Doppler finding with registry index 0.6, and the right is a patient with a high registry index 0.8 due to diabetic nephropathy. Renal parenchymal disease can be divided into glomerular and tubulointerstitial diseases according to the main component of involvement. In glomerular disease, Doppler registry index is usually preserved, while in tubulointerstitial disease, registry index is usually elevated. Because of this difference in Doppler registry index, when you see a patient with a high renal cortical echogenicity, we may add a comment of glomerular or tubulointerstitial disease if we have Doppler registry index information. Although cortical medullary differentiation is maintained, renal cortical echo is high in this patient, registry index is normal, and this patient probably has a glomerular disease. This patient has high cortical echo, has small cysts, and the registry index is elevated, so this patient probably has a tubulointerstitial disease. Next is focal lesions, mainly regarding renal masses. The most common renal mass found on ultrasound is a simple cyst, while the most common solid renal mass with internal vascularity in adults is renal cell carcinoma. However, there are indeterminate masses with mixed cystic and solid components. In general, if a renal mass is mainly cystic, it is more likely a benign lesion, while a mainly solid mass is more likely a malignant tumor. The presence of vascularity in the solid-looking component is important, so again, Doppler ultrasound is very important in this regard. Here is a mass with mixed cystic and solid components. There are prominent vascular flow signals in the solid-looking components, and so it is probably a renal cell carcinoma. And the mass was taken out and was a clear cell renal cell carcinoma. This darker area is a cystic component filled with hemorrhagic fluid, and these slightly yellowish areas are solid components with prominent vascularity. How about this case? Mainly cystic mass with some septa inside, and is probably a benign septate cyst, but color Doppler ultrasound shows a very important finding, which is a strong color flow signal in the septa. We need to make sure that this flow signal is a true signal and is not an artifact. The best way to confirm the nature of this flow signal is spectral Doppler ultrasound, which shows the true arterial flow signals. And now the diagnosis is probably a neoplastic cystic mass and probably a cystic renal cell carcinoma. CT was done and it shows faint septal enhancement. Surgery was done and it was a cystic renal cell carcinoma of clear cell type with tumor tissues along the wall and septa. The most common condition we may confuse with true renal tumor is a prominent column of Burton. Normally, a small amount of renal cortical tissue protrude between the renal medulla, and they are called column of Burton. Sometimes this centrally protruded column is unusually large, and then it may mimic a renal mass, and then it is called prominent column of Burton. Here are two different patients with similar masses with similar size and echo. One is true renal cell carcinoma, and the other is prominent column of Burton. Can you tell which one is which with these grayscale images? Probably not, but if you turn on color or power Doppler ultrasound, then it is clear which one is which. The upper region is probably pseudomass, prominent column of Burton, because vessels run through the lesion without any mass effect. But in the lower lesion, vessels are deviated around the lesion, indicating true mass, renal cell carcinoma. If this differentiation is difficult with Doppler ultrasound, CT scan is needed. This is another example of prominent column of Burton. Color Doppler ultrasound well shows vessels running through the lesion, and it is easy to make a diagnosis of prominent column of Burton. We do not need a CT scan, and the ultrasound follow-up will be enough in this case. Next thing to see is stone or hydronephrosis. This size stone in the calyx is easy to find out, and Doppler twinkling artifact is helpful to detect stones. Twinkling artifact is especially helpful in detecting small papillary calcifications that appear as hyperechoic dots. How about this case? Can you detect the renal stone in these grayscale ultrasound images? 27번부터 다시. How about this case? Can you detect a renal stone in these grayscale ultrasound images? How about these color Doppler ultrasound images? You may see weak twinkling artifact here in this color Doppler, and now it will be easier to localize echogenic stones here in the grayscale images. As you see in this case, twinkling artifacts are useful in detecting stones or calcifications, even if twinkling artifacts are weak. I was interested in twinkling artifacts a long time ago and wrote an article in AJR. And this article in Radiology by Dillman reported that twinkling artifacts has 55% sensitivity for detection of renal calculi observed as CT. It is easy to make hydronephrosis when we see dilated renal pelvis and calyces as continuous structures. And if we identify the relationship between the hypoechoic renal medulla and the end of dilated calyceal tips, it is helpful to confirm that these are dilated calyces. This close relation between the calyceal ends and the hypoechoic medulla may help differentiation between hydronephrosis and parapelvic cysts. You may trace proximal ureter from the dilated renal pelvis, and you may detect the cause of hydronephrosis, ureter stone in this case. It may be difficult to trace the ureter if the ureter is not dilated enough, but if we put more efforts, often we may trace a less dilated ureter, like this case. This patient has symptoms of stone, but hydronephrosis was absent. With strong suspicion of a stone, I tried to trace the ureter carefully with the help of ultrasound. I could find a stone here in the proximal ureter here that has a twinkling artifacts posterior to the stone right here. In this case, these are dilated calyces. If we see these cystic structures and the hypoechoic medulla, but dilated calyces are not connected to each other, and the degree of dilatation is uneven, with lower polar calyx more dilated, and the renal pelvis is not dilated but contracted. Considering all these findings, we may have an impression that this kidney probably looks like this schema, and we may make a diagnosis of renal tuberculosis. The most common condition we may confuse with hydronephrosis is a parapelvic cyst. When there are multiple parapelvic cysts in the renal sinus area, like this example, they may look very similar to the dilated pelvis and calyces. However, we do not see close relation between the end of these structures and the hypoechoic medulla, and then we may suspect parapelvic cysts rather than hydronephrosis. If we have a difficulty in differentiation, we need IV urography or CT scan that clearly shows parapelvic cysts and no hydronephrosis. Lastly, we need to check the urinary bladder. We may measure bladder volume and residual urine volume, and we may see urine jetting from uretrovesical junctions with color Doppler ultrasound. In patients with hematuria or pyuria, we may see moving echogenic particles in the bladder. When a stone moves to the terminal ureter, we may see the stone through the bladder. Here is an echogenic stone in the right uretrovesical junction with a twinkling artifact, and we may expect this stone will pass out soon. Of course, we may detect bladder tumors if they are not very small and flat, but we should not use the ultrasound to exclude bladder tumors. Often, normal uretrovesical junction may mimic a small bladder tumor in ultrasound and also SCT, so we need to be careful. Bladder stone may be detected easily with the ultrasound by its echogenicity, posterior sonic shadowing, and also by its movability with postural changes. One thing we need to keep in mind is that bladder tumor with dystrophic calcification on the surface, like this case, may mimic a bladder stone. This is the summary. I talked about how I do the ultrasound of the urinary tract from the kidney to the urinary bladder according to the items I described in the ultrasound report. The ultrasound is very useful in the evaluation of the whole urinary tract, and Doppler ultrasound is an integral part of the ultrasound examination. If you have any questions or comments, please email me. And if you are interested in my educational website, please visit once. Thank you.